Now, let's begin this educational session, and I'm so pleased to introduce you to Chris Bartha. Chris Bartha is the Executive Director of Brain and Mental Health Program at Sick Kids. Psychiatry, telepsychiatry, neurology, neurosurgery, adolescent medicine, social work, and psychology at the Gary Hurwitz Center for Community Mental Health. She has over 30 years of clinical leadership experience and holds several degrees, including Masters of Social Work from University of Toronto. For 20 years at the Center of Addiction and Mental Health, CAMH, Chris has held various leadership roles across multiple clinical programs. At Sick Kids, she led the 2017 integration of former Hinks Dalcrest Center, now GHCCMH, establishing Sick Kids as one of the largest providers of integrated pediatric mental health services in Canada. Chris has authored and contributed to peer-reviewed publications, served on cross-sectoral committees and boards, and then been a champion and advocate for student education and improved mental health services for children and youth. Please join me in welcoming Chris.
Thank you very much, and thank you for that very kind introduction. And thank you for joining me this afternoon on a beautiful sunny Friday afternoon. My hope is to walk you through a bit of a story of what I and my team have gone through over the last 2.5 years as we've worked through the COVID-19 pandemic and its impacts in eating disorders, and I'll talk a little bit about mental health. I am a social worker by training. What I wanted to explain to you is how eating disorders fits into my current portfolio, because I have a very from Sick Kids Hospital to what used to be Hinks Dalcrest, one of the larger children's mental health agencies in the city of Toronto, now rebranded the Gary Hurwitz Center for Community Mental Health. And it's a mixed portfolio across 4 sites in Toronto. We have about 525 staff. We do about 80,000 ambulatory or outpatient visits annually. And what I'd like to say is we have about 100 social workers employed across the portfolio. So we're a very big social work employer, of which I'm quite proud. We do have a high degree of variation of the programs that we cover, and the whole goal of the program is to cover a broad space in terms of mental health, especially for some underserved populations, most recently of which are children who have chronic medical conditions and concurrent mental health issues, which is a somewhat under-recognized area. But in this portfolio over the last 2.5 years, I have spent the majority of my time working through what has been the pediatric pandemic, which is the very sharp rise in eating disorders, not just in Toronto, in Ontario, across the country, and even globally. And I want to tell you a little bit about that experience and where it leaves us as of right now. So the agenda for today and some of the goals in the presentation are to set the stage for you in terms of eating disorders, talk a little bit about the types of subtypes that we see in the pandemic experience, a few fast facts. I won't go too deep in the literature, but leave you with some references. Talk about our own experience here in Toronto with Sick Kids, what happened in Toronto, which is really representative of what has happened across the country and the world, where we are today, and what the implications are for clinicians, for people in leadership roles such as myself, for social work, who actually plays a very big role in eating disorders. Many social workers are therapists seeing children and youth with eating disorders, and the opportunity that comes out of what can only be described as a crisis that emerged in 2020. So we get started, just to sort of level set things in terms of what I'm talking about. There are a long list of subtypes of eating disorders. I'm only going to mention the top 4, and actually within the top 4, during the pandemic, the top 2 that we would have seen in my hospital primarily fell into the categories of anorexia nervosa and atypical anorexia nervosa. This is what we saw when we saw a steep rise in children and youth presenting with eating disorders. But ARFID, avoidant restrictive food intake disorder, we commonly see that at Sick Kids as well as bulimia nervosa. And these are well-known diagnostic categories that we use for the purposes of assessing and also designing treatment plans for patients who present. Just a few things about eating disorders in children and youth. Their prevalence rates in adolescents between the ages of 13 and 18 is about 2.7%. The onset is typically with very young children, ages 12, upwards of 25, although, again, during the pandemic, we've been trending downward, seeing children as young as 9 or 10 presenting with a fairly serious eating disorder as a result of a number of things I'm going to talk about later in the presentation. Now, you can achieve very good treatment outcomes in eating disorders if you have good, effective treatment that is accessible early in the onset of an eating disorder. And it's not atypical for a lot of young people to require ongoing management after they have recovered. But where there is quite a high degree of complexity, where treatment is not available or it comes very late, there is the reality that there can be a significant mortality rate for young people and young adults with eating disorder. It has the highest risk of death of any mental illness, resulting from the fact that there are many medical aspects to this particular illness. And eating disorders is separated out from other psychiatric disorders, but it's not uncommon for there to be overlap of anxiety, OCD, depression. And we definitely have seen that in the last couple of years, where increasingly we are identifying kids and youth who would present with concurrent psychiatric and eating disorders. And that just adds to the rising complexity of trying to find an effective treatment. There are really 3 major areas of evidence-based treatments for eating disorders. The first is medical stabilization when required for kids who present who are quite medically unstable and who need hospitalization. This is a collaboration between pediatricians, nurses, and dietitians play a very important role in medical stabilization in hospital. The gold standard for outpatient care and treatment is something called family-based therapy, and this is overwhelmingly delivered by psychologists, social workers. Psychiatrists are also involved, but not so much. It's typically delivered through psychology or social work, and it was a therapy that was developed at the Maudsley about 30 years ago, and it really is considered the ongoing gold standard in the treatment of eating disorders, and it's done on an outpatient basis. With increasing complexity, a couple of other models have been added to the overall toolkits that clinicians have. Dialectical behavior therapy and eCBT are newer approaches that have been integrated where FBT alone is not effective with the young person. So I'm not going to go into a lot of detail about eating disorders and the clinical models that are used in the treatment of eating disorders, but I offer you a couple of excellent websites that have great resources that you can go to. The Ontario Community Outreach Program for Eating Disorders has been around for about 25 years. They are rebranding to a new name called Eating Disorders Ontario. It's not on their website yet, but I am pretty sure they're going to be doing that this year, so you may see a bit of a transition there. They're excellent at posting the latest publications from peer-reviewed journals that are very helpful to clinicians. And then I just offer about Kids Help. That's a Sick Kids website that offers information in very plain language for families, for young people, for professionals that are cross-sectoral. And the one thing I would point out about some of the new publications that are coming out, so you'll see the Canadian Practice Guidelines for the Treatment of Children and Adolescents with Eating Disorders. I love that they have a plain language summary on their academic paper, making their findings and recommendations even more accessible to the average practitioner who doesn't have a lot of time to wade through extensive amounts of literature. So a little bit about what we do at Sick Kids, just to set the stage. So we provide the full continuum of services at Sick Kids. It starts with outpatient treatment, that FBT model I mentioned. We're introducing DBT increasingly. We're very fortunate we have an interprofessional team that is made up of social workers, psychologists, child and youth workers, nurses, dietitians, pediatricians, and psychiatrists. This is very intensive work with a large number of professionals who are collaborating to have a relationship with the family and guide them through what is quite a demanding therapy to execute at home. It says mild to moderate. I can tell you at our hospital, and similarly to most hospitals across the country, the mild kids are waiting longer because moderate to complex types of kids are coming in more and more frequently and have to be triaged up in order to get them care to try to prevent a worsening of their situation. But when we have children and youth who present with moderate to complex or even severe disorders, we're moving into day hospital type models. And for the kids who are most unwell, inpatient medical stabilization. At Sick Kids, we have a shared 12-bed inpatient unit, shared meaning that half of it's for eating disorders, the other half is for psychiatric crisis and psychiatric intervention. We are full all the time, and even today, out of our 12 beds at Sick Kids, 11 are eating disorders, leaving very little capacity for mental health admissions at the hospital. And I'll talk a little bit later about how we're managing that. One team manages both populations, which is a very challenging thing to do because we use different models with the different populations. So I'm just going to dial it back to February of 2020. It was business as usual at Sick Kids. The pandemic had not been called at that time. We had a number of really important initiatives underway. We had launched at Sick Kids a mental health strategy. That's the first one that Sick Kids has had in its history. It was considered very important, given the rising recognition of mental health need amongst children and youth. We're launching a major renovation of our inpatient space, that 12 beds I talked about a moment ago. We just launched a big urgent care clinic initiative that was doing very well, allowing us to offer an alternative to admission to hospital for mental health patients who could be seen very quickly for stabilization purposes. And we decided at that point we were going to redesign the eating disorders program because we recognized we were seeing on a gradual basis rising complexity, more kids with concurrent psychiatric and eating disorder issues, and we had a pretty concerning outpatient waiting list. And so we wanted to launch a redesign. So we launched that redesign in the months prior to March of 2020, not knowing that we were going to be dealing with the pandemic at that time. We were already really aware of the gradual increase in mental health and eating disorder volumes across the hospital and the community sectors. We already had treatment waiting lists of about 6 to 8 months on average, sometimes a little less, sometimes a little more. And we were talking about inequity of access to care, not just in Toronto, but across the province, and acknowledging we hadn't made much progress in addressing that. Then in March of 2020, I think we'll all remember, the first wave of the COVID-19 pandemic arose, and we went into lockdown in Ontario and Quebec and other parts of the country. And in Toronto and in Ontario, non-emergent hospital activity was rapidly paused. We had never done anything as extreme as what happened at that time. And many of us will remember ministry directive after ministry directive that came out several times a week or every week, asking us to pivot and change some of our practices. Primary care and community care were severely constrained, and there was this huge seismic shift to virtual care, virtual health care, virtual school from home, virtual work from home. Everybody was at home. The adult hospitals were overcome with COVID patients. Those were all the headlines. And there was this creeping onset of significant social disruption. I don't think any of us appreciated what that was going to translate into, but it was across employment, financial, marginalized, and racialized populations were severely impacted and in a disproportionate way, and many other impacts that I know you're already aware of. And at Sick Kids, for the first time, we had this huge decline in activity within our hospital. Our corridors and our waiting rooms were empty. We pivoted to virtual wherever possible, and only emergent admissions of kids came into the hospital. And it became quite unusually quiet, but it didn't last. By July of that year, we began to see this creeping trend of every key mental health indicator at Sick Kids starting to creep upward. Our emerge volumes started to go up. Our urgent care clinic appointments, we had to increase the number that were available. There were requests for psychiatric consults, and eating disorders started to really rise up in a way that was very noticeable. We saw younger kids with lower weights, longer hospitalizations. And some of the acuity data that we have, and acuity data is really the number of kids coming in who have suicidal ideation or deliberate self-harm. That's how we've been measuring it. We began to notice trends there. And overall, our referrals were going up. And I'm just going to show you a little bit of data that just speaks to some of the numbers. So our emerge department and urgent care visits, so that's our gateway into the hospital for eating disorders and psychiatric care. So for psychiatric care, so this is not eating disorders, this is psychiatric care, these numbers are extraordinary in terms of year-over-year increases. So a 51% increase in eating disorder visits that required a psychiatric consult over 3 years went up 51%. and then 99% increase in the number of urgent care appointments we had to offer to kids who were not necessarily needing to be admitted, but needed some immediate intervention for stabilization purposes. And you can just see the green line, which is 21, 22, as compared to the other lines, everything is going up. I included this data because this data really struck us as quite important. So this is the number of kids, the rising rates of distress as measured by suicidal ideation and self-harm, and many of our eating disorder kids present with these kinds of concerning presentations. And I'll just point you in the direction of the younger kids, the blue bar and the orange bar. And you'll see how much those two age groups are rising. And that would be materially different from what we were seeing at sick kids prior to the pandemic. And we were also seeing kids who had no previous history of any of this type of presentation coming into the emerge. So again, these were trends that were, I think, big signals that something was going on. Here's the data on our inpatient admissions. So we were tracking the number of kids that needed a bed coming into sick kids, and you'll see that in 2021, so that's the year of the onset of the pandemic, we had a big jump up in eating disorder patients. To have a 35% increase in 1 year is very remarkable. That would not have happened in previous years. And we were seeing similar trends with our psychiatry patients. So it's all a story of this sudden increase that would have been quite uncharacteristic of previous trends. I include this slide just to present the same data in a different way. If you go to the red line, that's March of 2020, the pandemic, first lockdown happens, and you'll see that year over year, we see this dramatic increase in the number of admissions by month into what is only 12 beds at sick kids for mental health and eating disorders. And I just point you to the orange line. The orange line is the number of kids that would have needed a bed somewhere else in the hospital because we ran out of space on our inpatient unit. We were full. And you can see that there's a dramatic difference between prior to the pandemic and after the pandemic started. Same picture here. This is eating disorders total admissions by month. Again, you can see the surge. And you can see the surge very particularly if you just look here, because this is where we really saw a massive change. Sorry, I'm not great with this cursor, but a massive change here with the number of kids presenting and how fast we had to respond to the number of kids presenting who needed an inpatient admission and how many beds we needed to find outside of our own unit. And this story was replicated across the province. We're not unique in this regard at all. It would have been replicated at other hospitals, children's hospitals in particular, in Toronto, Ontario, and Canada. Many of the kids who presented in those months presented much more medically unstable than we might otherwise have seen, and that translates into longer hospital stays. And that translates into even greater pressure on our bed flow and being able to admit these children and youth in a timely fashion. And this was a significant challenge for the system. We now have kids staying longer. We used to, on average, have them stay 3-4 weeks. Now it's between 4 and 8 weeks that would be an average admission, and that is a significant change in the management of resources. I'll just step back for a minute and say, the global context since COVID started is that we have definitely tracked rising rates of mental health distress. Early in the pandemic, there were a few publications that came out that suggested perhaps it wasn't as significant as we thought. But I think now that we're looking back retrospectively and we have the benefit of a number of meta-analyses of numerous studies. This is my colleague, Dr. Sunita Munga's slide, where she did a review of the number of studies that have looked at elevated symptoms of depression and anxiety in children and youth. And you can see that the numbers are quite high, and this is international data. Emergency department volumes internationally are tracked as rising with these populations everywhere. And the ED bridging work, which is emergency department bridging work, which is that urgent care work that we do to avert admission but offer mental health intervention and stabilization, has risen everywhere dramatically in an attempt to manage this rise in demand with very constrained resources. At Sick Kids, that's been our story. It's amplified the reality that prior to the pandemic, we were already dealing with a very taxed mental health and eating disorder system to begin with. And this was layered on top of that. So in looking back, I can tell you that we were not prepared in March of 2020 for what evolved in the months that followed. And many of you may have seen newspaper headlines, and apologies to my colleagues who are not from Toronto. I realize these are very Toronto-centric newspaper articles, but this was replicated everywhere in Canada, this conversation about this dramatic rise in eating disorders and the pressures that providers were experiencing. We had an overwhelmed system on the outpatient side that was already taxed pre-pandemic. Inpatient capacity was taxed, and very importantly, primary care doctors, parents, and caregivers were very alarmed because many of the early warning systems we would have formerly had were not available to catch kids before they became much more severe in the course of this disorder. Coaches, teachers, people that were involved with children and youth activities who might have noticed something and raised a flag with a parent that something might have been off. These early warning systems disappeared with the lockdown and the very strict confinement restrictions that we were living with, and everything being done virtually from home, and kids in bedrooms maybe not being seen as much as they ordinarily would have. Dr. Holly Agostino is an adolescent medicine specialist and works with the Eating Disorders Program at Montreal Children's Hospital. She gave an excellent talk at the Children's Healthcare Canada Leadership Forum in April of this year. And she's been part of a national study that looked at the impact of COVID-19 on eating disorders. We know from the literature internationally that other providers have been reporting extraordinary increases, 100% to 200% increases in children and youth presenting with anorexia nervosa. That higher acuity that I spoke about that leads to higher and longer hospitalizations. And initially, a lot of the literature focused on children and youth who had pre-existing eating disorders prior to the pandemic. We knew that they were likely to already be vulnerable because they had a pre-existing experience with an eating disorder. The Canadian study, led out of Montreal, looked at new patients presenting without that history. Across 6 sites, looked at data from 2015 to November of 2020, so that's roughly waves 1 and 2. And the findings were quite striking and validated what a lot of clinicians were saying. New diagnoses were coming at an average of 25 per month formally. They rose to 40.6 per month in the reporting period. Hospitalizations, formerly 7.5 per month, rose to 20 a month. And then increased severity, loss of weight, more medically unstable, greater need for hospitalization. And these findings were the steepest in Ontario and Quebec, where the highest numbers of COVID cases were identified, and we had the strictest rules for confinement and school closures. This data is just from the Ontario Health website, just as a reminder of these huge peaks and valleys we've had in terms of COVID-positive hospitalizations. Testing is now not such a reliable measure of COVID because we don't have that as a standard all over the province, but certainly hospitalizations is a good metric to track in terms of the state of COVID in our community and the impact on the healthcare system. So why the surge? What was driving all of this? And I'm just going to flag 5 things that have been talked about that we found were reported by our families, our youth, and our clinicians were noting, and the literature seemed to validate. First of all, school provides an enormous amount of routine and structure for eating, breakfast, lunch, and dinner, and snacks. The lockdowns and everyone coming into the home environment where that structure disappeared overnight, as well as the structure of after-school activities, interacting with coaches and teachers and parents, those early warning systems I talked about, that had a very big impact on the eating patterns of children and youth who might have had a predisposition to an eating disorder. The loss of social support and social isolation. We know that peer connectivity is really important and it's a protective factor for kids. We know that that connection to peers was greatly disrupted by the lockdown. Many youth were in their bedrooms with their laptop and trying to relate to all of their friends, teachers, and others on a computer screen. If you were a young person that might have had any challenging family dynamics that formerly you would have maybe had a break, left the home, gone to the park, met up with friends, all of those coping strategies immediately evaporated with the lockdowns. And now those teens were immersed in those family dynamics that may have been triggers for disordered eating. A lot of discussion about social media and virtual everything. We've been, we've translated our lives into the virtual arena. It's both a positive and a negative thing for adolescents. It enabled them to stay connected, but it also served as a trigger, especially for adolescent girls. The early part of the pandemic and our focus on the internet, you'll recall lots of activities focused on eating, diet, recipes, exercise. We knew back then that 30% of patients with eating disorders had a comorbid anxiety or depression, and that social isolation would probably have been amplified by the fact that they couldn't connect with their friends. And finally, we know the challenges to the healthcare system and access to healthcare. This has been ongoing, it continues now. But during waves 1 and 2, a lot of routine screening and clinic closures impacted primary care and the ability to follow up on a physical exam with a young person and access other kinds of testing. You do need a physical exam with a young person who has a suspected or confirmed eating disorder, weight, observation of the patient, blood pressure checks, ECGs, all of these things are part of a standard medical workup on a young person, and you can't do it through virtual care. You can't do it effectively. Virtual care is also very effective unless a young person doesn't have privacy and feels like their conversation will be overheard in the clinical context. And that's been a significant issue that's been identified across mental health in the delivery of virtual care. It applies to eating disorders as well. So with all of this and staying in a bedroom, not being seen, wearing baggy clothes, parents would report that they actually didn't realize what had happened until things had proceeded to quite a significant level. And they were very concerned about the presentation of their young person, which is what led to all those emergency hospitalizations that were so different from previous patterns. We also saw a few changes. Greater acuity intensity of the behavioral presentation of young people, a lot more behavioral outbursts and angry kinds of interactions with parents and caregivers, kids presenting not just with sort of resistant to eating, but full-on food refusal by the time they were presenting for care, and then a rise in self-harming behaviors. And for family-based therapy, for parents to manage that in the context of this higher acuity is very, very challenging because family-based therapy engages parents heavily in monitoring eating and meal supervision, and they're very involved in those processes at home. And if you have a lot of outbursts and challenging behavior from your adolescent, it can be extremely stressful for parents. So we, as eating disorder programs, were already challenged prior to March 2020, and I've just walked you through some of what happened as the pandemic unfolded. The surge created enormous additional strain on the existing system and wait lists. Some programs had to raise their criteria for admission. You had to be more acute in order to be accepted into the program, and that meant that the kids who had less severe symptoms where earlier intervention might have been very effective had to wait longer. And much of the burden of care shifted to primary care doctors and community providers who formerly would not have been doing this type of care and found themselves feeling quite uncomfortable in the management of these kids who were medically and medically complex, and from a psychiatric perspective, even psychiatrically complex. So I'm just going to do a deep dive into Toronto and what happened with us, because I think this story played out not just in Toronto, but in other parts of the province and country as well. We had our immediate response to the crisis that was starting to emerge in the summer of 2020. And I'm going to walk you through what a system response looked like in Toronto, how incredibly important that was. That leads us up to the summer of 2022, which is now. Where are we at? And what are we doing about this as we look ahead into the future? And a lot of important players are part of this conversation. Eating disorders programs, Ontario Health, the ACUPED program that I mentioned, and Kids Health Alliance, which is a partnership between children's hospitals that is looking at particular pressure points in the pediatric system and trying to come up with proposals and solutions. So I'm just going to remind you, this is where we were at in 2020. I put the circle around where things got extremely challenging for all the hospitals. That orange line, that is the bump up of the number of kids who presented to hospital that needed a bed, outside of the blue line that was already at full capacity. And you'll see that that beginning has stabilized a little bit, but it's still definitely higher than pre-pandemic numbers. So this is where we were at, and this is what we were managing at Sick Kids. And our story was not unique. We had extraordinary operational challenges. We needed to find additional physical space outside of our mental health unit. That is a logistical challenge in hospitals. Everything is connected through technology. You move one thing, 7 other things need to be adjusted. So we opened a second unit to bring our eating disorder surge patients together into one unit because we were borrowing a lot of staff who needed just-in-time training from our experienced staff to provide effective care at the bedside. And this was a fantastic effort that engaged so many different members of our teams in order to support the delivery of care. We were also dealing with all the COVID restrictions at that time. Child and family-centered care involves a very open receptivity to parents and caregivers being in the hospital with their children all the time. And we had to impose within the hospital, based on the Ministry of Health guidelines, some significant restrictions on who was allowed in the hospital. 1 patient, 1 caregiver. Medical stabilization involves bed rest, cardiac monitoring, and encouraging the young person to eat with a special approach to meal support and supervision. It's 3 meals, 3 snacks a day, very high caloric intake. Each child probably requires about 4.5 hours of direct supervision to ensure that they're eating in order for that to happen. And the work is to assist them to become metabolically stable, to hit a target weight so that they are more stable. And all of these kids come in with concerningly low heart rates. These are all risk factors, and that's what leads to medical monitoring and bed rest as the first intervention for these children. But from the get-go, parents are a very important part of the model. So we really had to work something out because there were so many restrictions on who was allowed in the hospital. And virtual in that context was incredibly useful. And so we did have virtual coaching and education sessions. We had parents on tablets. And we had exceptions where 2 parents were permitted into the hospital for the purposes of planning, education, and discharge planning. But this was a very challenging period for all of the hospitals. By January of 2021, we were quite clear that we had to get a handle on this situation. We needed more of a systemic response. And so in Toronto, the GTA department chiefs of pediatrics, who are at many of our major hospitals, and our eating disorders program, they came together for a collective system-based response. And there were 5 key activities that enabled other hospitals to admit some of these children and allow sick kids to have a lower number of children presenting. So that included other hospitals admitting these children, creating a community of practice where we generously shared information with many of our colleagues and providers. We worked with primary care providers to manage kids on the waiting list. ACUPED provided really excellent training that helped shore up resources and the system. And the pediatric hospitals came together to collaborate on an advocacy proposal to Ontario Health to invest in additional resources in order to address this extraordinary pressure. And this was quite successful. So you can see in this same graph that our hotspot is March of 2020, and then the other 2 green lines really indicate in January the GTA collaborative efforts between sick kids and our very important partners across the sector came together. And really by November, as we headed into flu and viral season, which is another important thing in pediatrics and in the hospital sector, because those patients need to be taken care of too, we see a bit of a stabilization, and the dotted line is what we think is going to happen this year. And the numbers are still quite high. Even today at sick kids, the numbers have gone up. And the other striking thing about the kids who are coming in are they tend to be more on the high end of the acuity complexity continuum, requiring a lot more resources, planning, and intervention. I should say that in the middle of all this, we renovated our mental health unit and worked through a renovation, which was very challenging, but we now have a beautiful new unit, which we very much appreciate. And we too, just like every other healthcare provider, have been and continue to deal with human resource shortages, which complicates expanding our services. So it does feel on any given day that we are swimming upstream in healthcare and swimming upstream in eating disorders and mental health care, given The need is great, the demand is high, and the complexity is getting higher. However, I am an optimist when it comes to what is possible for us to do as a sector in collaboration with our colleagues and what we've learned from the pandemic. And that would be from the clinical end of the spectrum to what we do in leadership to support system building and support our teams who are doing this work. So I'm just going to walk you through some of the challenges which translate into opportunities if we take advantage of this situation and we realize that we are obliged to do something important to address what we've learned over the last couple of years. So our patients, our clients, and our families, their complexity is changing. We have more psychiatric comorbidity. We have a lot more social complexity and diversity within the populations that we serve. And our models of care don't always fit well with the families and young people that we are serving. Yes, family-based therapy is the gold standard. It's evidence-based. It's been demonstrated to be highly effective. But increasingly, we're finding that it's not enough. And for some families, it's actually too much. The demands placed on some parents are not reasonable. And it's very disheartening for them to not have other options that they can offer their young person or that can be offered to them as parents. And I think we have a real obligation coming out of the pandemic to really ramp up research, innovative model development, and better preparation for the different kinds of families that we're serving who have eating disorders and concurrent comorbidities. We have a human resources challenge. I think we hear about this every day in the media that we are facing a lot of burnout within our healthcare professionals. Next to nursing, mental health care professionals are the second group that have faced the highest degree of demands and the greatest burnout as a result of the pandemic. And that's not surprising because mental health has been such an issue arising from the pandemic across the lifespan, but inclusive of children and youth. We have a short supply of current and future professionals, and eating disorders is an area where very specialized training is required. Really good supervision helps enormously. Cohesive teams, interprofessional in nature, all working together is the best way to design and deliver treatment plans. And it's complicated. Our kids are complicated, our families are complicated, and we want to think these treatment plans through thoughtfully and in detail and in collaboration and partnership with our families. This is very resource-intensive work to train people, to retain people in the field, and we have an opportunity to do things differently in the future with our partnering universities and colleges where there's likely a need to rethink the way we're training professionals to enhance the curriculum and to support a longitudinal strategy to have greater capacity as it relates to healthcare professionals, especially in eating disorders. The pandemic and virtual care introduced a new competitor, which is the private sector treatment companies. Now, they have brought tremendous capacity to the system, and virtual care is an excellent added component to mental health care. But there's no doubt that it is a very competitive labor market right now, and publicly funded systems are competing, not just with each other, but now with the private sector. I don't have a solution for that right now. I'm just going to name it as something that's something we really do need to think about in the context of our human resources strategy. There's a lot of great jobs in the publicly funded sector in eating disorders. They're purposeful and meaningful, and they're different from the private sector. And I think we need to amplify those opportunities. This is a reality that we cannot ignore, especially for those of us who are needing to ensure that every day our programs are staffed. Virtual care. Now, virtual care exploded overnight, literally, in mental health and healthcare overall. Mental health picked it up the most. And now we're trying to rebalance the system to figure out who's a good candidate for virtual care, where is it the preferred model for a young person and their family, and where is it simply not reasonable because it's not safe. You need a physical exam, you need a relationship, you need to be in the room with the clients, and they need to be in the room with you as the therapist. And I think there's been a lot of good literature that's come out about the appropriate use of virtual care, guidelines for virtual care. Virtual care is very tiring for clinicians to be on a screen all day, every day. Clinicians have reported a high degree of fatigue doing only virtual care. So we're still figuring out what does a healthy hybrid model look like, not just for patients and families, but also for clinicians. And I raise that because clinician fatigue is another important issue in mental health and eating disorders. These are very, they can be very intense jobs and roles. And clinician fatigue is a really important health-related indicator that we need to pay attention to in order to have a resilient system that is available for our patients and families. The last thing I'll talk about is the opportunity to build an integrated system and the importance of advocacy. So when I talked about the GTA collaboration that actually stabilized inpatient capacity within the GTA, that was an organic collaboration that was led by a group of division chiefs and then all of their colleagues who came together and recognized, there's an opportunity, there's a burning platform here. We have an opportunity and we need to take advantage of it to work together because we have an obligation to take care of these youth. We can't not take care of them, so we need to come together. And that's exactly what they did with weekly meetings and touch points and extraordinary participation in coming together. We need to leverage that, and those division chiefs are continuing to meet, I'm delighted to say, because what we need is actually what the Ontario Health Group is talking about right now, which is a really well-defined continuum of care, inclusive of early identification and intervention for children and youth with eating disorders, all the way to acute care. And of course, what we want to do, to the degree possible, is avoid as many children as possible reaching that very acute point in the continuum of care, because it's much harder to dial things back from there. There's a big discussion about equitable access across the province because that doesn't exist right now. There isn't equitable access across the province. And innovation in care delivery models, as well as better understanding of trauma-informed approaches when working with eating disorder kids, some of whom are coming through historical traumatic experiences that create another level of complexity in managing their eating disorder. Ontario Health has been very active in the eating disorder space. They've struck a group now looking at quality guidelines that would guide the development of a system, and they've brought together a lot of interested eating disorder people who want to inform that because there's a real sense of the compelling need to get on top of this, as we know we're likely to have a number of years ahead of us where we're working our way through the backlog of kids who are now waiting for eating disorders treatment. The average length of wait, probably a year for outpatient treatment, unless you come through an emergency track, which would be from hospitalization and then back to outpatient service, which is a really alarming number. So this work is now very important. So how am I doing for time? Okay, so it's good I'm on my last slide. So just some final thoughts on where we were back in 2020, where we have traveled to now in 2022, and where we need to go. And this is a very, very challenging area to get traction in, to get progress moving. Healthcare in general these days is very challenging. Many of the challenges I mentioned to you in eating disorders are being experienced in other parts of healthcare as well. And eating disorder treatment in and of itself, for the reasons I mentioned, training staff, retaining staff, and the complexity of our patients and families, is also very challenging. But the pandemic generated a crisis that demanded a response. And the response launched some innovative approaches and solutions that now need to be leveraged. And we have new collaborations that need to continue. And I think social workers play a very important role in this space. Social workers understand clinical care. They're delivering a lot of it themselves. Many of them work in eating disorders. We operate from a strengths-based orientation or paradigm, which is very important in eating disorders. We tend to be solutions and system and solution-focused thinkers. So we see how the dots connect and how doing one thing in one space can benefit something else. And collaboration is a big part of a lot of social work activity, whether you're working with a a family and caregivers, or whether you're working with system partners, or whether you're working with your own colleagues within your own agency. Collaboration is part of a lot of the work that we do, and collaboration is what's going to help us move this eating disorder system forward as we work our way through what has happened during the pandemic. The pandemic had, I would say, consequences that we didn't even anticipate in 2020. We didn't anticipate what would happen. But we know a lot now. It's 2 years later, and we have very important findings and information. We know a lot more now. Our challenge is to leverage all that knowledge, to integrate it into a plan, and to work collaboratively with many different partners to really try and do something very important, very meaningful, and very fast in the next few years so we can properly meet the needs of the kids and families who are out there waiting for our help. And maybe I will stop there.
Thank you so much, Chris, for that wonderful presentation. And we have a few questions coming in. I'm going to try to share space with our laptops here. So one of the questions that we have is, would you say that young folks that were trying to create some control in the environment and that felt out of control in terms of this sort of surge of eating disorders, in terms of solutioning as to why one of the variables that you saw the surge happen during those lockdowns?
Yeah. I mean, clinically, I think some kids would have reported that as one of the drivers that contributed to the onset of their eating disorders. Other young people reported that, you know, they started to exercise, they started to control their caloric intake, and it just got away from them. They just got, you know, it just sort of took over in terms of more of a pattern of behavior that they couldn't stop. And so that's what they were reporting to us, and that's one of the things that became a focus of treatment.
Perfect. The other question was just around the peaks that were happening in the November, December months. You know, we noticed them in 2020, and then you sort of slowly the same place and kind of in 2021. Do you think that this is related to the stress of the holidays, starting of school, the pandemic lockdowns? I mean, it's multivariable, but
it is. We used to do a lot of forecasting based on seasonal patterns that were part of the historical presentation of kids, and it's very difficult to do that now. The seasonal patterns have changed a lot, but there's no question that exams, academic performance, and anxiety about that are often associated with a pop-up in the number of kids who are presenting.
And even when you're thinking ahead for this coming year, you've got a bit of a projection around that same sort of...
Yeah, like, well, we'll see what happens with school in the fall. We're going back to in-person school in the fall. That's a good thing.
Right.
That's a good thing in terms of returning to routine and structure. But kids and youth have been out of that routine. And for some of them, because more kids are feeling more anxiety, for some kids it may be more stressful. So we're hoping some of our system response processes are going to position us better to manage the increased volumes that may present in the fall, and we'll see.
Perfect. Also, in terms of, for all of those members that are listening, in terms of any kind of training or education specific to eating disorders, we have some interest around that. And you also mentioned that it's a field that you'd like to have more interest in, and social workers are very well suited for this type of work.
They are.
Talk to us a little bit about that.
Well, the work in eating disorders, once medical stabilization is achieved, is a therapy. It is a therapy that is provided by people who are trained in psychotherapy and family therapy. And it's very family-based for many of our patients and families. And social workers are very well trained in family-oriented, systems-oriented therapy. So they're very well positioned to be part of the eating disorders continuum of service. I mean, I would direct people to ACUPED as a great starting source for eating disorders training, and they are increasing the amount of training that they're making available. So that's a great website to start with.
And if you can spell it out for us, Deb, our comms.
It's going to be rebranded Eating Disorders Ontario. So that's easier than ACUPED, but I think ACUPED is OCOPED.
Perfect. She'll just put that on the chat for those that are interested. Are there opportunities to volunteer
in eating disorders treatment?
In the genre, I guess, in clinics, and I know there's opportunities at Sick Kids, but if you're specifically interested.
So it's an area where we do take a lot of interprofessional students, so social work students and psychology students, are always welcome to do their placements and apply for placements in eating disorders programs, not just here in Toronto, but across the country. And it's not a space that we have a lot of volunteers, namely because it's so highly specialized from a clinical perspective.
And there's probably substantial training that goes to ensuring. Thank you. And I just wondered, actually, this was a question I had during your presentation, which was excellent. In terms of initially when you started up, you talked about there's a lot of interprofessional care that goes to setting up and the structure of caring for these kids as they're coming in. Can you talk to us just a little bit about your experience and how those different professions are connecting with families? And you know, I would assume that it would be quite a meaningful experience no matter who, because you're working in a team.
Yes, and it's staged and sequenced.
Right.
So if a child comes into hospital for medical stabilization, their primary interactions with the inpatient team will be with pediatricians, nurse practitioners, dietitians, child and youth workers, and nurses. And they get a lot of one-to-one oversight because so much of their inpatient experience is focused on rest in bed because you're not medically stable, eat.
Right.
It's a big part of inpatient hospitalization is eat. It's based on a specialized dietitian's recommendations on a very particular diet and caloric intake. Once patients are stabilized, they move to a different team, which is more inclusive of social workers and psychologists, psychiatry, and medical monitoring remains an important part of the model. That might be done by a pediatrician or nurse practitioner, but that fades back a bit because the focus in outpatient care is therapy. What were the psychological things or the patterns at home that we need to adjust that contributed to the onset of these behaviors, these eating behaviors that led to the eating disorder? And so you really do need to have that young person medically stable to successfully move on to that second stage. I think families meet a lot of people in the eating disorder treatment experience.
That's great. Thank you so much. I'm just looking through our chat. I think we've addressed most of the question. I really want to take an opportunity to thank you. On behalf of the college, I'd like to present Chris, you with a token of our appreciation.
Thank you.
The college has made a donation to Sick Kids Center for Community Mental Health Therapeutic Garden, which was chosen by you. The Therapeutic Garden is one way that Sick Kids Center for Community Mental Health supports children and youth with mental health issues and their families.